6:30. Well, I might get started. Thank you all for joining us today. Happy Wednesday, and welcome to September's Sexual Wellness PD series. Tonight, we have a very exciting topic, improving healthcare access for women in rural and regional Victoria, Women's Health Mobile Clinic, presented by Nurse Practitioner and Midwife Louise Holland and co-presenting with Nurse Elise Kornmann. Before we begin, I would like to acknowledge the traditional owners of the lands and waterways across Australia from which we are all joining this evening. I pay my respects to elders past, present, and emerging, and I extend that respect to all the Aboriginal and Torres Strait Islander peoples with us today. I also acknowledge the deep importance of Indigenous knowledge in the field within sexual and reproductive health. Wherever we are zooming in from, we are on Aboriginal land and sovereignty was never ceded. Before we begin, everyone, just a couple of housekeeping notes. We kindly ask for everyone to stay on mute during the presentation. Please feel free to share your questions in the chat though, and we'll have time at the end to discuss and answer those questions. This session is also being recorded and will be available on the Search website next week as well. Excellent. So let's introduce our presenters. So firstly, I'd like to introduce NP Louise Holland. Louise has worked in the field of sexual and reproductive health for the last 24 years, offering a wide scope of services for women's health and sexual health issues. Louise works autonomously as a nurse practitioner at Bendigo Community Health Services, BCHS, in the Sexual and Reproductive Health Hub, working alongside medical practitioners and sexual health nurses. Louise is also a registered midwife and has worked in this field for over 23 years in remote WA, the Kimberleys and regional Victoria. Louise continues to work in Bendigo Health as a nurse practitioner, coordinating the surgical abortion service for the Women's Health Clinic. Louise has extensive experience working with adolescents and people from culturally diverse, vulnerable, and disadvantaged backgrounds. Thank you, Louise. And now I'd like to introduce Nurse Elise Kornmann. Elise is a highly experienced women's health nurse with over 15 years' experience in sexual and reproductive health. She is deeply committed to improving access to care for women, particularly those living in rural and remote areas and from culturally diverse communities. Elise currently holds dual roles, so she works as a nurse counsellor at Bendigo Health Breast Screen, where she has supported women for over a decade through the breast screening and diagnosis journey with compassion, education and care. In addition, Elise is the Mobile Clinic Nurse Coordinator for Breast Screen Victoria. In this role, she coordinates the delivery of the Women's Health Mobile Clinic program, which brings vital sexual and reproductive health services to women who may otherwise face significant barriers to care, and which we'll all hear more about tonight. Elise's work reflects her strong commitment to health equity, culturally safe care, and community engagement. She brings rich insight into the challenges and rewards of delivering mobile healthcare across Victoria. Thank you, Louise and Elise, for presenting tonight. Before I hand over, just for those who have come late, if we can please keep ourselves on mute for the presentation, and any questions, please pop in the chat and we'll answer those at the end of the presentation. Over to you, Elise and Louise.
Thank you, Carly. Thank you for making the time to join us to learn about the Women's Health Mobile Clinic and for the opportunity to share updates and connect. Next slide, Carly. So before we begin, I'd like to continue in the spirit of unity and respect. The Women's Health Mobile Clinic acknowledges the First Peoples of these lands and the waterways. We recognise their deep connection to the earth and the importance of holistic wellbeing as we embark on our shared journey towards women's health. Louise and I are here in Bendigo on Dja Dja Wurrung country, and together we strive for a future where every woman has access to care that honours both her physical and cultural needs. So my name's Elise Kornmann. I'm the Mobile Clinic Nurse Coordinator. My role is managing local community engagement. I visit each location, coordinate booking, secure treatment room spaces, and conduct nurses with onboarding and ongoing support with clients' results and follow-up. And I also step into the clinical nurse role as required. I've had the pleasure of working with Louise Holland for the first 3 months of the program. Although we've collaborated for many years, it's been rewarding to work together on a program we're both deeply passionate about. So her dedication, insight, and shared enthusiasm have made this experience truly meaningful. Thanks, Elise. I'll let you introduce yourself.
Thank you, everybody. It's so wonderful to see so many people here this evening. Yes, so as a nurse practitioner in women's sexual and reproductive health, it was a bit of a no-brainer for me to apply to do this role earlier on this year. And then hopefully tonight we'll be able to share some of our learnings and certainly some of the joys and challenges that we encountered when we're on the Nina van. Thanks, Carly.
Next slide. So the Women's Health Mobile Clinic is a 12-month pilot program that launched in January 2025. It's led by Breastfeeding Victoria and funded by the Victorian Department of Health. And it's all about expanding access to free, high-quality care for women and gender-diverse people with a service, particularly in regional and rural communities. So the Women's Health Mobile Clinic builds on the success of our mobile breast screening program, but takes it further by offering comprehensive sexual and reproductive health services, all delivered in 45-minute appointments by a nurse practitioner or a highly experienced sexual and reproductive health nurse. The care is completely free, confidential, and inclusive, so it's designed to remove common barriers to care. Services include cervical screening and bowel screening, contraception advice and access, including IUDs and Implanon, STI education and testing, menstrual, pelvic and bladder support, perimenopause and menopause care and management, pregnancy options counselling, and also referrals to GPs or specialists for ongoing care. So where do appointments happen? So while the van does contain a small refurbished consultation space, we quickly learned that many appointments are better delivered in private clinic rooms in nearby health services or community centres, especially for sensitive procedures or conversations. So the mobile van space is still very useful for storage to assist with setup and the setup of each clinic at each location. So we offer interpreter services and disability access, and always try to create a safe space, welcoming environment. We work closely with the Aboriginal community controlled health organisations, ACOs, through the Beautiful Shore project, engaging in respectful community-led planning. So how to book? So appointments can be made by phone by scanning the QR code on posters and postcards, to request a callback, or by visiting the Breastfeeding Victoria website. So in short, the clinic is about bringing care to where women are, removing barriers and giving people the time and space they need to talk about their health. Next slide. Thanks. So our amazing team. So the clinic is supported by Breastfeeding Victoria's operations, communications and engagement teams under the leadership of Project Manager Kate Wilkinson and Project Lead Jinli Chu. So clinical staff includes a nurse practitioner or sexual and reproductive health nurse, mobile clinic nurse coordinator, Elise Kornmann, and Dr. Magda Simonis, who is a GP who provides clinical supervision and ensures clinical governance. So this model is focused on improving access to essential health services for women, offering both flexibility and privacy where needed. So since January, we've welcomed to the team 8 new staff, so including 3 sexual and reproductive health nurses, 4 nurse practitioners and 1 GP. So many interviews and inductions which have kept us on our toes. Next slide.
Okay, so recruitment. So for nurses, it's been challenging, largely due to the clinical scheduling and the remoteness of the locations that need to fit this work in their already busy professional and personal lives. Here is, on this slide, is the image of my accommodation in Edenhope, which was my first location for my first week, because there was no other accommodation available. So recruitment is looking positive as we have most of our locations for the year covered with either a nurse practitioner or a sexual and reproductive health nurse, which is exciting to maintain the consistency of the service and the scope and practice and delivery across the region. Thank you.
So the Women's Health Mobile Clinic has visited 15 locations so far. So as you can see, we've covered a wide area already by following the Breast Screen Nina bus scheduled during the pilot. We have also visited ACOs listed above, so through the Beautiful Shore project. So we engage in respectful planning conversations with each ACO to confirm interest and to tailor the service to the community needs. So we're currently in South Gippsland, so we are in Foster at the moment until the 12th of September and then head to Yarra for 4 weeks.
Next slide. So one of the key lessons we learned very early in the beginning was early engagement and promotion of where we're coming. So the planning starts from a strategic level quite early, but we start planning and engagement and promoting well in advance. Appointments opened up 4+ weeks before our arrival to the locations. And what is absolutely critical in the time that we've been there is identifying the local champions, people who are respected, trusted, who can help build awareness of the program in the communities that we visit. These often include health workers, teachers, counsellors or local business owners. This slide is a photo of an amazing champion in St Arnaud who was going door to door with all our promotional material, encouraging people to come to the clinic, which ended up being so successful. So we promote through local media, through the radio, newspapers, community, school newsletters and social media. We actually have Elise come to each location and visit local businesses, knocking on the doors, providing our health promotion material in the cafes, sporting clubs, handing out the flyers wherever we can go. And as we probably would understand in small rural communities, word of mouth is one of the strongest tools. The locals trust the locals. So Marg here in St Arnaud was an absolute epitome of how a local person can galvanate the community to attend the clinic. She went above and beyond securing a room for us in the actual local council building. She organised a physio's bed and even a portable hand basin to ensure that we could run the clinic with hygiene practices. So we had to get creative at times, but the local people were absolutely to their credit, incredibly encouraging to support us. One of the important things we realised very early on is clear messaging about the services. So the two services, the breast screening and the women's health consults, each have different booking systems. And so our role was really to very early on communicate clearly and simply how to book into the women's health clinic. It was an aim to reduce the confusion and help people navigate their options easily. And it did take a little while for that to happen. Yeah. Thank you. So one of the greatest opportunities while I was travelling on the van was some opportunities in regards to community outreach and education sessions. So in addition to the promotion, we ran face-to-face sessions with a wide range of local community groups. We went to the high schools. I spoke to the Year 12 students at Dalesford. We went to the football and netball clubs of some of the country towns. We visited a disability support program. We visited the Kornmann community community groups, the neighbourhood houses, backpacker hostels. These sessions were designed to raise the awareness and answer questions and explain how to book appointments. And so a lot of people actually booked on the spot or shortly after those face-to-face visits. So, yep. So one of the things that we found in the communities is around targeting our message to our audiences. So for the students in one of the country towns, we went to the high school and we got the wellbeing teachers to organise a lunchtime session that we could talk to the year 10s, 11s and 12s. And it was really effective in terms of ensuring we talked about a private confidential space which was not available in their town in regards to sexual and reproductive health. So it was really important that when we got to know the community, we targeted our conversations to those groups. We were very fortunate to use local radio and media to extend our reach. We had an interview on a queer focus interview on the Dalesford radio to help connect people from the LGBTQI+ community. We did interviews on the ABC in Horsham because we actually had quite a few communities in that area. And certainly there's more ABC radios in Gippsland. So one of the things we realised was the impact on being trusted and our visibility. So these sessions help to ensure that the Nina Van's Women's Health Clinic was visible and that the communities trusted that it was actually an experienced clinician coming into their community, so that to reduce the anxiety that they may already have in terms of accessing a consultation. So, as we know, it's very important to choose our partners, and we've been incredibly encouraged and inspired with our partnerships with the women's health organisations throughout Victoria. We've had great support from local women's health organisations that help promote the service in their networks, including us in their community events, promoted our education sessions in the areas that we are there. Their partnerships are crucial in helping us to connect with more women and ensure our messages reach the right audience.
Next slide, please, Carly. Thank you. So health service connection and referral pathways. So while community engagement helps promote the clinic, linking in with local health services is just as important. Especially to support clients after we leave. So before each visit, we connect with the sexual and reproductive health hubs, GPs, hospitals and pharmacists to map out referral options. So this is especially helpful for new nurses who may not be familiar with the services in the area. So we partner with bicultural and multicultural health workers to improve access and cultural safety. These meetings give us crucial local knowledge, what services are available, how accessible they are, and where the gaps might be. So it also helps build trust and collaboration with local providers. So we're not working in isolation, but part of the broader health system in each town. So even though the clinic is only there for a short time, women's health needs continue. So we focus on providing clear next steps, warm referrals and follow-up information. So this kind of groundwork has been essential to ensuring that the clinic runs smoothly and most importantly that women have continuity of care that's local where possible, practical and supportive.
Thanks.
So closing the care loop. So a core part of our model is making every client leave with a clear plan. So whether that's follow-up care, test results or referrals, at every appointment, clients are told how and when they'll receive results, so expectations are really clear. Each person is also given a personalised care plan outlining next steps and any referrals required. So ideally, the nurse who sees the client follows up on their results directly, but in some cases, especially when nurses are finishing up on the program, the mobile clinic nurse coordinator steps in to manage those follow-ups. So that includes chasing up any outstanding results, speaking directly with clients, and making sure the referrals are sent to services. So with the client's consent, GPs are also copied into the referrals to support continuity of care. So we're not replacing general practice, but working alongside it. So these systems and handover support the Women's Health Mobile Clinic nurse and coordinator helps ensure that no one falls through the gaps once the mobile clinic moves on. So we have additional support for our nurses. So our nurses also receive weekly supervision with Dr. Magda Simonis, which provides them with clinical support and a space to discuss any complex cases. So importantly, our nurses can also contact Magda at any time if they need guidance. Or anytime they need guidance or support.
That's correct. Yep.
Next slide. Thanks, Kylie.
So these are a couple of examples of the clinic spaces that we're able to secure. So it's a clinic space in Birchip and in Nil, which we were incredibly fortunate to be able to receive these spaces. So it meant that we could have a very private, confidential area. We had access to bathrooms, access to the beds, and access to actually air conditioning when I was there because it was very warm. But it just goes to show that the communities, once they realise the program's coming, they're just so pleased that it's coming that they really try very hard. This happens with us working directly with the staff in those health services, and realistically we give a tour of the facility. We're introduced to the key staff. We often have support from admin in terms of some of the administration needs that we have, the support from the multicultural support in some of our communities, physio, pathology, medical imaging, which has really set us up for success in the smaller communities. Thank you. So the service uptake. So of course our reporting is important, and for the first and second quarter, this is just a little bit of an overview of what we've achieved. So we saw 286 individual clients with a notable 100% increase in clients access from the first quarter to the second quarter. 335 appointments were delivered, the majority face-to-face, with most lasting 45 to 60 minutes. And this really highlights the complexity that we found of clients' needs and the value of extended consultations. Client feedback consistently emphasised the appreciation for the time, space, and respectful environment to discuss their health. It also reflects the importance of providing flexible and client-centred care, especially in the communities with complex and unmet needs. In some communities, seeing people before work, seeing people after work was absolutely considered fantastic in terms of the flexibility of the service.
Next slide. Next slide. Thank you.
Thanks, Carly. So who are we seeing? So in terms of our clients, the 286 clients so far are quite a wide range of age, which I suppose can be expected. Most of the people, however, were between 40 to 69. Accessing to services, about half of the clients had access to a regular GP. So that really highlights the gap in primary healthcare services in some of the regions where we visited. The majority had Medicare cards. A quarter of them had healthcare cards, which also can help with affordability of follow-up. In terms of the diversity and inclusion of our clients, Aboriginal and Torres Strait Islander clients made up of about 2% of our total clients, which is relatively low and points to the need for stronger engagement in the future. In terms of our cultural and linguistically diverse clients from background, about 7%, depending on the town. We went to one town where there was a significant population of Karen people, the town of Nil. So that was fantastic in terms of that. A small number of clients identified as LGBTIQA+, and a fewer than 5 clients identified with gender other than woman. Thank you.
So as the graph shows, the majority of clients, as Lou said, were aged 40 to 69, which reflects the expected uptake for breast screening. So, however, women's health consults are relevant across all age groups, including younger women accessing sexual and reproductive health care. So we've seen clients from teens to women in their 80s and 90s, demonstrating that the clinic is reaching a wide cross-section of the community. So this broad age spread supports our commitment to continued targeted outreach for younger audiences through schools, youth centres and sporting clubs, and older women through community groups, aged care networks and health providers. So this data reinforces the need for an inclusive service model that supports the health needs of younger, middle-aged and older women. Youth engagement and healthy ageing support remain central to our outreach and education approach.
Thank you. Next slide. Me? Okay, so this graph shows the types of services provided during the appointments delivered so far. And as expected, the most common were cervical screening, contraceptive care, menopause, perimenopause, and bladder conditions. And for example, one woman came in thinking she was just tired, but having the time to describe her symptoms and what was happening on it was quite classic that she was going through menopause, which had been dismissed by her GP. Over 60% of the clients presented with multiple concerns, often combining reproductive health issues with chronic or emotional health issues. We've heard things like, I've been meaning to get this checked for years, but didn't get around to it. We've delivered over 120 cervical screening tests, many for women who were 10 to 20 years overdue. A number of women chose self-collect, which they said felt more comfortable and gave them more confidence to participate. Contraceptive care education was quite a major need. In one town, we're able to provide IUDs insertion with support of the local hospital team. We've also distributed the bowel testing kits and provided education around bowel screening. So beyond what's shown in the graph, we also clear trends in mental health issues, including stress, anxiety, isolation, especially in farming families, and the women taking that load from their partners. We also notice a reasonably, in particular parts, low health literacy in some groups. For example, a Kornmann woman said, I only go to the doctor if I'm really sick. So these stories kind of highlight how the mobile clinic is not just delivering services, it's creating access, building trust, supporting women to take control of their health issues. So to add this success, we actually have now conducted an IUD clinic in Foster, enabled by the experienced IUD inserting nurse practitioner with clinical support in a safe environment. And this has really expanded the scope of services in this area significantly. Thank you. So barriers reported by clients. So this slide highlights some of the most common barriers that clients shared with us during their appointments. Cost, transport and long travel times were recurring issues, especially in the more remote areas. The photo here shows the road to Nil, which really captures how isolated some of these communities are. Many clients spoke about being uncomfortable seeing a male provider, particularly for sexual and reproductive health concerns. Others reported that there was just no local services available or that they face very long wait lists, especially for specialist care. Privacy was another key issue. for these clients. In small towns, people often worry about being recognised or judged. One challenge we didn't really expect was the rejected specialist referrals. So women would come to our service saying that their GP had sent a referral to a specialist, but it was rejected. And often this was because the woman hadn't completed the referral criteria, and it was too hard to get back into that GP. So we were able to support that quite a bit, actually. This highlights like how the gaps in the system, like the system services, like the incomplete assessments, the lack of continuity as it going to a different GP and starting the referral service all over again, or blocking and delaying the access to the care that women need.
Thank you. Next slide. So we're just going to go through some case studies. So these outcomes are best understood through lived experience. So case study 1, closing prolonged screening gaps. So a 60-year-old woman came to the clinic on her colleague's recommendation. She hadn't had a cervical screening in over 20 years and was deeply anxious it might now be too late. She avoided care due to discomfort with male GPs and fear of what the results might show. With time and reassurance, she agreed to have the test. Her results came back clear. She was incredibly relieved and said she wouldn't have accessed this care without the mobile clinic. Case study 2, adolescent seeking private guidance on contraception. Because she knew the clinic staff and was afraid of being judged by her small town community, a 14-year-old who was sexually active refused to go to the local doctor for contraception. She became aware of the availability of private, confidential care when Nurse Practitioner Louise came to her school. She discreetly went to the Women's Health Mobile Clinic after school to get advice on sexual health and contraception, highlighting the value of services that are judgment-free, accessible to young people in rural communities. Next slide, thank you. So case study 3, managing complex sexual and reproductive health issues. So after having bad experiences with a GP and gynecologist, a 36-year-old woman with polycystic ovary syndrome who was diagnosed at age 18 sought a second opinion for managing her periods and fertility issues. She found out about the mobile clinic. She was relieved by the convenience and not having to take more time off work because she couldn't afford to travel to Melbourne for care. Our nurse took the time to listen to her worries and provide her with individualised, compassionate care. She felt more assured and in control of her reproductive health after being directed to the Sexual and Reproductive Health Hub for more assistance. Case study 4, flexible and collaborative care. So a 40-year-old woman with social anxiety and heavy bleeding came in for her first cervical screening. She didn't feel comfortable with her male GP and had no partner for support. After a gentle, no-pressure consultation, she phoned days later wanting an implant on. She didn't have a car, so the script was dropped to her home by the nurse. A week later, she returned with her support worker for insertion. Ongoing care and follow-up were arranged through the nearest Sexual and Reproductive Health Hub. This kind of flexible, thoughtful care helped her take the first steps in managing her health. Next slide, thanks Carly. So clients are invited to complete a survey following their appointment. The most common reason clients gave for attending the service was, I wanted to have a longer conversation about my health. The second most common reason was convenience, followed by difficulty accessing the services they need locally. This included challenges such as being unable to make an appointment nearby, the Pacific service not being available, and or long wait times. So the survey received a strong response rate, providing valuable insights into common themes and community perspectives. Next slide, thanks Carly. So I'm going to share with you what the community is saying. So on accessibility and rural healthcare gaps, One woman stated, "Would be keen to have this service more regularly available in our rural community." Another client expressed, "Great service for depleted country practices." On privacy and trust, a client said, "Thank you for coming to a rural location. So important for us to have confidential services. I don't want to see my GP about screening." On feeling listened to and supported, one participant shared, "Amazing service. Answered so many questions today that usually a GP would run out of time for." A client told us, "Explain details in depth so that I can really understand what's going on." Another shared, "It's allowed me to discuss and address issues I've put on the back burner." On the overall experience, a client described it this way: "Fantastic booking process, lovely lady who took the booking, very informative appointment, answered all my questions and more." So their feedback highlights the clinic's value, accessibility, and the depth of care it brings to areas where healthcare options are often limited. Next slide, thank you. So this project has been an incredible experience. The community response has been overwhelmingly positive, with strong uptake and engagement. The appreciation and trust shown by women in these rural and remote communities continues to reinforce just how important the service is. So where to next? The Women's Health Mobile Clinic will be in Gippsland until the end of the year. It's currently in Foster and will be in Yarram, Mallacoota, Orbost and Omeo, and a couple of Aboriginal communities along the way. So to book an appointment, clients can call us on 96750050. I know people don't remember numbers, but people can visit thebreastscreen.org.au for more information on services and dates. So thank you for listening. Has anyone got any questions? Please let us know.
Fantastic. What an amazing initiative and project and service that is clearly just offered such amazing access for rural and remote women. So congratulations, Louise and Elise. That was really great information. Thank you. I can't see the chat. Was there any questions, Soph?
Just a lovely comment from Courtney. I'm not sure whether, Courtney, you want to actually speak to what you wrote, or you're happy. I'm happy to read it out otherwise, or
Oh, I'll speak. I don't know. I'm in the dark here, but that's okay. I work as a team leader in supported playgroup, and I actually work in Birchip, Sea Lake, Witchy Proof. Yep, there's a couple of places, Donald, Manangatang, so in smaller communities, and I have I'm on different committees, and just sometimes in conversation with women, this menopause comes up, and it's like a lot of women don't know much about it, and they get overwhelmed by what they're looking at online. Some women have talked to their doctors, but they don't really feel like they've got the support. So I'm just it was good to see that that woman example that you gave was really tired and just put it down to general tiredness, but it was perimenopause, menopause related. So I think there really is a gap, and I think that yous can be meeting that need, and that's really good. But I do hope that there's more support in that area across rural communities, because I know you use one initiative. Yeah, that's all I'll say.
And I'd have to agree, like Courtney, majority of clients, their feedback has been just really appreciating that longer consultation, to have that time, because we did mention how they often come in for one concern, but 60 to 70% of the time it's often a number of things. So it's just their GPs just haven't got that time to. And so I think the important part is that we are getting to these communities early and being able to provide those education sessions while we are in town, not only promoting the clinic, but being able to provide, those requests around menopause sessions, and then also in schools. Lou did a lot of work with STI contraception sort of advice and education, which they loved, and our nurse Robin's been doing that in Gippsland as well, which the students are really enjoying it.
No, that's really good. I know in for example, in Donald High School, my best friend's a teacher there. She's in wellbeing, and she has to organise the health talks, and she's a science teacher. Like, and that's a big thing to put on, you know, the teachers on top of their workload to, and then making it appropriate and so that, you know, so the children respect you afterwards as your teacher as well. So that's good that you can go in as professionals and do that. So thank you again. I'll be quiet now.
One of the really interesting things about engaging with younger people is around you know, trust and getting into the community earlier on. And I had quite a few experiences where you were there for a week and you saw predominantly the people who were able to navigate the booking in system and were, you know, kind of probably the you know, the 40 to 60-year-old age group. And so the success of getting younger people, and often it was the last 2 days that you were there, that they kind of, you know, a young person decides, okay, I do want to see someone, this person might be okay, I can get there, you know, so all those steps that an adolescent might go through to actually venture into the clinic. And I think we've had some experiences now of the van being there longer than just a fortnight, which I think will be interesting in the evaluation at the end of how long you are in a community, particularly the communities where people move from, you know, an hour between communities, where they can move from one community to another community in terms of accessing it. So we had people in Donald coming to Birchip, people in Birchip going to Warwick-Nabil, people in St Arnaud coming across to Birchip because they didn't make it to the St Arnaud clinic because it was all booked out. So that was that was really useful too. Yeah. But, you know, for younger people, it was a struggle because often, you know, we potentially weren't there long enough for them to feel comfortable to come in within that time frame.
That perception at the start, thinking it was just for breast screening age, they were not thinking that they were eligible for the Women's Health Mobile Clinic. So it's really sort of making sure we have that really good overview of what the service is about and what we can provide, and make sure, yeah, we're educating the schools beforehand. So, yeah.
Melissa has asked about setting up in other areas that are lacking services like GPs, like Cardinia. Is that on the agenda or in a plan? And Claire is also trying to establish a local mobile service regional to Druin, and is very impressed with how you've been promoting this. And she asks whether you still consult at all from the van, or is it in storage?
So in some locations we couldn't secure a room. So in one location I could only secure a clinic room one day a week of the fortnight that I was there, and that was the podiatrist room. So that was reasonably adaptable because I actually needed to do an examination on the people that booked in. So the rest of the consults were actually in the van, in the little converted consult room, which was interesting because there was the other service, the mammogram service and the reception service. So I felt that the more we promoted and looked at opportunities for separate clinical spaces in the locations, that became a much more acceptable place to see people. But absolutely, you can do the clinic from the van. That was really kind of what it was set up with. And what we needed to do is to really create great relationships with the local GPs, or to encourage people to go to the sexual health hubs or of their choice or preference if they needed an examination, and I couldn't provide that in the consult room on the van. Yeah.
Definitely does limit your scope, doesn't it?
Yeah.
And I suppose as far as going to other destinations, we understand that it is a 12-month pilot and funded by the department. So it is really important that we are getting all the feedback and all this data, the evaluation. So, you know, and as you can see by our surveys and the uptake by community, it's been really successful. So we really hope that we can continue and get to those other locations that desperately need further support.
So just for people to be very clear, the Nina van had already had all the towns and communities sorted out before this project came up. So Nina and the Women's Health Mobile Clinic followed all those communities. So we couldn't stay. We did have stayed in a community, say, a week longer in a clinical consult room. So the mammogram program ceased, their booking ceased, and then the nurse stayed an extra week. So that was a little bit of flexibility, but going to those locations had already been predetermined by the Nina Van's schedule for the year.
Yes, definitely securing that clinic space in the town does, leave us with that flexibility to stay longer or, so it's just, opened up the scope, definitely.
Great.
Kate mentions that in Mildura, one of the things that stood out for her was that, or for them, was that oftentimes locals want to take a health concern to someone from outside the community. So the availability of this sort of service to someone who's a fly in, fly out was advantageous. So
fantastic. Melissa has her hand up as well. Oh, you're on mute. That old chestnut.
Oh, let's get while she's getting sorted, I'll see if there's any chat around having pharmacies obviously get involved and
Can you hear me
that
now?
old chestnut as well.
Can you hear me now?
Yes, we can.
Oh, thank you very much for all that information. I was the one that asked the question about Cardinia. So I work for Southeast Public Health Unit, and we service 11 LGAs all the way to Cardinia, from Stonington, Cardinia. Now, my role is focusing on increasing cervical screening and HPV vaccination and finding who is missing out in these areas. So even though it's not rural, there are still, like many populations that are missing out on either screening or vaccinations for whatever reasons. And I've been in discussion with, for example, the city of Cardinia or Cardinia Shire, because of their, like a lot of issues they have with access to GPs or not enough GPs and other sessions, and that's why I was inquiring. I've been looking at this for a while, wondering if it was something that will be, I know it's a pilot, but something that will be possible to extend to groups that are missing out, even in the regions that are not considered rural. So I just thought I'd make that comment because I have a lot of discussions with, like, for example, City of Cardinia, and they are asking all the time, how can you, I'm not the one that does the screening or anything, but I'm collaborating with so many organisations, and they want to know how we can increase that. And same with Headspace. We've been discussing with Headspace, for example, in Narre Warren, and trying to work out how we can get how they and we, or as a group, get younger people to come in to Headspace for HPV vaccinations, and understand that it's not just for mental health support, and it's still an ongoing sort of program that we're trying to look into. So just some food for thought, really.
Yeah, absolutely.
Yeah, thank you very much for that feedback. And I think one of the things that will evolve...
Sorry, I can't hear you now.
Oh, can you hear me now?
We can hear you.
Okay. One of the things that I think will evolve over the time is the relationship between the Women's Health Mobile Clinic and the virtual Women's Health Clinic that was launched mid-year as well. And I think there will be a great, kind of alignment in terms of referrals to and from, and also, particularly where there potentially is an area where there's a lack of access to GPs or services, and local public health units and different agencies being able to really promote that service as well. Yeah.
Because I think you have the virtual clinic coming on in a few weeks. Yeah, so that's great. But Melissa, please send us an email because we're happy to hear where you think areas need to be served. So, I can forward my details to you, and we can be in touch.
Fantastic. Yes, we will have the virtual Women's Health Clinic come on for November's Sexual Wellness PD series, and just really discussing that link between, rural providers and, increasing that access and the collaboration between, the Mobile Women's Health Clinic and other providers and pharmacies as well. So that'll be a really great session. So excellent. Was there any other questions, Soph, in the chat?
Asked how you defined your CALD clients. What was the parameters around how you identified those? Are you aware of? There was a slide that mentioned that you had 7 clients.
Yeah, so people who were filling out the survey, the question is what country you were born in. And that's how we identified that. Yeah. It didn't really matter how long they'd been.
Yes.
With us in Australia.
Thanks for that. Some data, like for our federal funded programs, their CALD definition is born outside of Australia and speak another language other than English in the home. So, for example, children that are born outside of Australia but only speak English in the aren't counted as CALD. So I just wanted to clarify, just because it's interesting how it skews stats. Yeah.
And just the last comment, Kate was agreeing with the discussion around other allied specialties, and also that the mental health locals and urgent care clinics also need to play a role, obviously, in the full picture. So,
Excellent. Was there any other questions from anyone? No. Okay. Well, for that, I will say good evening to everyone, and I thank you so much, Louise and Elise, for presenting tonight. That was fantastic and such an amazing initiative and pilot that hopes to be continued, because it's really giving access to those who otherwise cannot get access to such important services. So thank you all so much for joining this evening. As I said, it will be recorded, so if your colleagues have missed it, please tell them that to jump on the Search website next week. But thank you so much, everyone, and have a wonderful evening.
Thanks for having us.
Thank you.
Take care. Thank you.
Thank you. Bye.
Bye.
What a great